راح نحكي الآن عن الأكني والروزاشيا which are very common conditions seen in dermatology clinic. Acne is a chronic disorder of the pilosebaceous unit. بايلو من hair. أي شيء له علاقة بالهير بسموه بايلو. فبايلر cyst هي عبارة عن cyst originating from the hair follicle. أونيكو له علاقة بالنيل. Onycholysis separation of the nail plate from the underlying nail bed. فبايلو سيبيشيوس يونت هي عباره عن ايش؟ سيبيشيوس جلاند اللي بتطلع السيبم مع الهير شافت والهير فوليكل. هلا البرايمري ليجن في الاكني از كوميدون. كوميدون simply it's a papule elevated skin lesion less than 0.5 cm in diameter without substantial depth. في عندي two types of كوميدون، في عندي الاوبن اللي بسموه بلاك كوميدون، وفي الكلوزد اللي هو وايت كوميدون. بكون فيها كمان papules, pustules, cysts, nodules and scar. Usually appears in the area which produces sebum. فما نتوقع يكون في عندي acne في البالمز أو السورز لأنه ما عندي sebaceous gland ولا في الجينيتال area. فusually it's seen on the face, neck, chest, shoulder area and the back. أنا بتعطيني polymorphic skin lesion. شو يعني polymorphic skin lesion؟ يعني different skin lesion at different stages. في عندي papules, comedones, pustules, nodules, cysts and scar. هلا الكوميدون عبارة عن بابيول. فليش بسموها بابيول؟ because it's specific for acne it's called a comedone. العربي يسموه الزوان. فالacne usually common at teenager group يعني female between the age of 16 17 male between the age of 17 and 19. هلا sometimes it can be complicated by pain, loss of confidence, depression, scar formation, pigmentation on the skin. That's why we need to treat acne at some point. نحكي شوي عن sebaceous gland. Sebaceous gland usually is responding to hormones, mainly testosterone. فbefore puberty we don't expect sebaceous gland to produce sebum. فعليها testosterone receptors وفي انزيم هناك اسمه 5 alpha reductase. هذا 5 alpha reductase عبارة عن انزيم بحول testosterone into dihydrotestosterone which is about 10 to 20 times more potent than testosterone in its testosterone action. هذا السيبم هو عبارة عن ايش؟ triglyceride, fatty acid, wax, squalene and cholesterol. كل هالاشياء are component of sebum. شو الفانكشن تبع السيبم؟ بعطي lubrication to the skin. فلوس اوف sebum بعطي dryness في السكن. بالنسبة للcauses of acne زي ما حكينا في عندي sebum production وفي عندي hormonal changes. هلا الهرمونز يا اما بكون في عندي high level of hormone هو testosterone أو بكون normal level of testosterone بس في عندي low level of sex hormone binding globulin. هاي proteins are secreted by the liver. إذا الليفل تبعهم low بتخلي الفري testosterone relatively high. فبالتالي its action will be exaggerated. فزي ما حكينا من ناحية pathogenesis في عندي sebum. The second factor that might cause acne في عندي poral occlusion. شو يعني poral occlusion؟ يعني obstruction في البورز اللي هي مسامات الجلد محل ما الاوبننج اوف هير فوليكل طالع برا السكين سيرفيس بصير عندي اوكلوجن. زي ما حكينا السكين از دايناميك ستراكشر في عندي تيرن اوفر للسيلز. اذا كان ريت اوف برودكشن اعلى من ريت اوف شيدنج مش راح يكون عندي سكيل فورميشن. انا بالاكني ريت اوف برودكشن زي ريت اوف شيدنج لكن الكيراتينوسايتس موجوده على السيرفيس اللي هي كونيوسايتس. when they get dyed they are over adhesive they get stuck to the skin surface للبورز. فليش جيت ستاك؟ بحكوا انه في جينيتك ابنورماليتي في الستراكشر تبع السيل عشان بعض المرات بنشوف الاكني ان فاميليز. والشيء الثاني component of the sebum make those cells too sticky so they stick on the surface of the pores and causes poral occlusion. على نتيجة البورال occlusion بتراكم السيبم في البايلوسيبيشيوس يونت. هلا البايلوسيبيشيوس يونت في عندي بكتيريا بسموها بروبيونيبكتيريوم اكني. It's a normal flora gram positive roots موجودة على السكين سيرفيس. هاي بتعيش في البايلوسيبيشيوس داكت. بتعيش وين؟ على السيبم. بتاكل ترايجليسرايد تعطيني فاتي اسيد. فاتي اسيد بيشتغل as chemotactic factor. شو يعني chemotactic؟ brings the inflammatory cells from the blood vessels للديرمس. فبصير عندي inflammation بالسكين. والinflammation usually exaggerated by this bacteria through something called toll-like receptor 2 which is part of the innate immune system. هلا سلايد نمبر 9 بتلخص كل الاشياء اللي حكيناها. فالكوزز اوف اكني from the above عندي بورال اوكلوجن، في عندي هايبر كيراتينايزيشن، عندي شويه ثيكنينج في السكين. هذا الثيكنينج حكينا الكونتنت تبع السيل يمكن يكون ابنورمال. الشيء الثاني البيهيفير تبع السيل يمكن يكون abnormal. فالسيلز should within 60 days they should shed from the skin surface وبطلع new cells مكانها اللي هي corneocyte. بس هون في الاكني السيلز are over adhesive، فبالتالي بتعمل لي occlusion. انا شو اتوقع الاشياء الثانيه يمكن تعمل لي occlusion؟ sometimes الكوزموتكس، الاويلز، التارز. الناس بحطوا ايش؟ ميك اب كثير مثلا على الفيس، او ناس بيستعملوا فازلين على الفيس، هذا كله راح يعمل لي اوكلوجن للبورز، فبخلي البيشنت مور لايبل يصير عنده اكني. لو نزلنا تحت في عندي بكتيريال كولونايزيشن، في عندي بكتيريال اوفر جروث هون. فهذه بكتيريا بروبيونوبكتيريوم اكني جرام بوزيتيف رودز بتعيش على ايش؟ السيبم. بتاكل ترايجليسرايد بتعطيني فاتي اسيد. الفاتي اسيد بيشتغل از كيموتاكتيك فاكتورز، فات induces inflammation. Inflammation will brings inflammatory cells, neutrophils and T cells للبايلوسيبيشيوس يونت. هلا السيبم زي ما حكينا من السيبيشيوس جلاند. السيبيشيوس جلاند before puberty they are not active، ولكن هي after puberty بتعتمد على الهرمونز من الاندروجين to produce sebum. هلا some oral contraceptive pills which are progesterone based might have androgen-like effect. فبالتالي OCBs sometimes some types of OCBs might induce acne. فعرفنا الباثوفيسيولوجي will know the treatment for the acne. Simply إذا عندي occlusion I need to remove that occlusion بكريمز أو إلكتروكوتري، أشياء بسموها كوميدوليتكس. كوميدون من كوميدون، ليتكس لايسز. لما نعمل لايسز هالكوميدون بنشيل الكوميدون. So we reduce the acne. عندي bacterial overgrowth I need to give antibiotics and medication that has anti-inflammatory effect. عندي sebum production I need to give ايش؟ medication to reduce the sebum secretion. عندي hormonal changes effect of testosterone على sebaceous gland I need to block the hormones receptors موجودين على sebaceous gland. This will reduce the sebum. في عندي inflammation I need to give medication to reduce the inflammation of the skin. So the treatment depends mainly على الباثوفيسيولوجي understanding. طيب بالنسبه لسلايد نمبر 10 راح نبلش بالشمال. عندي شيء بسموه مايكرو كوميدون والصوره اللي بعدها كوميدون زي ما حكينا. بس في عندي accumulation of sebum accumulation of keratinocytes على السيرفس تعمل لي occlusion للبورز. فبالتالي الهير فوليكل down there will get dilated. لما يصير في dilatation بصير في عندي ايش؟ papule. لما يصير في inflammation هاي papule بصير inflammatory بصير لونها ريد. لما يصير في invasion of neutrophils للسكين سيرفيس بصير في عندي pustule. اوكي. لما يصير في more swelling و more obstruction at the poral site more swelling underneath راح يصير في عندي ايش؟ deep lesion. deep lesion شو بسميها؟ nodule. هاي nodule contains sebum and inflammatory cells. if it ruptures inside the skin كل هالinflammatory cells والانزيمز موجوده فيها كولاجينيز والاستيز will be disrupted او distributed في الديرمس. الديرمس فيها كولاجين فراح يصير في ايش؟ digestion للكولاجين موجود في الديرمس. So we'll end up with scar formation. So we need to treat the patient and catch the patient before the patient develop scar formation. إذا صار في عندي scar formation loss of collagen then no medical treatment will be helpful. At that time we need to go for a physical treatment like laser treatment or surgery to treat those patients. فالدايت هلا شغله الدايت علاقته بالاكني is still controversial. Stress has been linked to acne بس دايت بيحكوا انه diet that has a huge amount of carbohydrate skim milk can induce acne in genetically susceptible patient. هلا بالنسبه لنا اهم شيء نعرف classification of acne mild, moderate and severe. ليش؟ treatment will depends on the severity. If it's mild we have only comedone for the skin surface. فالتريتمنت simply will be something to remove those comedones from the skin surface. إذا كانت moderate في عندي comedone وفي عندي papules و pustules. فالتريتمنت will be comedolytic creams أو lotions زائد medication that has anti-inflammatory effect and medication to reduce the sebum. إذا كانت severe بيكون في عندي nodules, cysts أو scar. At this stage treatment should be systemic. Otherwise the patient might end up with scar formation from the nodules and the cysts as they are deep lesions and they can rupture inside the skin leaving scar formation and post-inflammatory hyperpigmentation. طيب slide 13 الصورة على الشمال في عندي diffuse closed comedones. papule elevated less than 0.5 cm in the face of a teenager. So this is acne till proven otherwise. شو التايب اوف acne هون عندي؟ comedonal acne يعني mild acne. عندي closed comedone، ما عندي papules ولا pustules ولا nodules ولا cyst ولا scar. فعندي multiple papules. differential diagnosis group بسموها ethnic cell disorders. ethnic cell disorders. ethnic cell disorders هي skin appendages اللي هي الهير والسيبيشس gland. اوكي. الصورة على اليمين بسموها ايش؟ open comedone. ليش؟ because it has a black color. انا بحكي البلاك color هي عبارة عن بابيول، بس هاي بابيول it has an open surface. والبلاك كلر اجى من وين؟ يا اما ليبيد اوكسيديشن او ميلانين ديبوزيشن. Again in slide 14 في عندي ايش؟ closed and open comedones. هلا بسلايد 15 على الجهه الشمال عندي papular acne، يعني في comedones وفي inflammatory papule. الصورة بالنص فيها diffuse pustules and papules. الصورة على اليمين فيها ايش؟ nodules cysts. فالصورة اليمين this is severe acne. ليش؟ لأن عندي nodules أو cysts. هلا severity of acne doesn't depend on a number of lesions. If we have a patient with diffuse comedones all over the face, this is still mild acne. بس إذا عندي patient with single nodule أو single cyst أو single scar means severe acne. So on the classification of severity, we depend on the quality of lesions rather than number of lesions. هلا في severe form of acne بسموه acne conglobate. هي عبارة عن severe form of acne فيها nodules, cysts, scar. بس conglobate باللاتيني معناها balls. ف they are large multiple ball-like structures coalescent يعني مجمع with each other. Okay. ف sometimes there is some sort of sinus formation between those balls وفي pus formation و fluid exudation. فهي risky ليش؟ it might end up with scar tissue formation and pigmentation. سلايد 17 زي ما شايفين عندي severe acne conglobate على الباك على الفيس على الشيست. في other form of acne بسموه acne fulminans، هو another variant of severe acne. ليش سموه fulminans؟ لأنه because there is diffuse inflammatory skin response and also there is systemic inflammatory response. مش بس بالskin inflammation also goes through the circulation. يمكن يعمل لي joint pain, fever, proteinuria, high ESR, joint and muscle pain. Okay, فإتس acne بس هون inflammation is not only confined to the skin but extends beyond that to reach the blood circulation. صورة 19 شايفين على chest area diffuse inflammatory nodular cystic lesions وبيشنت عنده fever و joint pain. هلا في عندي variant of acne neonatal. ليش بتوقع neonatal عنده acne؟ لأنه في عندي transplacental hormonal passage from the mom to the baby testosterone which activates the sebaceous gland. فبصير عندي acne like lesions بالفيس. هلا infantile acne usually appears in males. Sometimes it can be related to immaturity of the adrenal glands. Mechanical acne زي ما حكينا في عندي rubbing للسكين against surfaces. بصير مثلا بالفيدلرز نيك الناس بيعزفوا كمان بحطوا كمان على الجهه الشمال فنتيجه الكرونيك فريكشن كمان مع السكين بصير عندي ايش؟ acne. tropical acne بصير البيشنتس who get excessive sweating بالتروبيكال اريا بصير خاصه على الباك بصير في occlusion للبورز وبالتالي بصير في acne. drug induced acne some patients who are on steroids, anti-epileptics, anti-TB medication, sometimes high dose B12, anabolic steroids and OCPs, progesterone based OCPs, they might have acne. الأكني بالدرج induced acne typically doesn't have comedones. بتكون عبارة عن multiple papules pustules. sterile papule pustule. أخذنا سؤال كلتشر حيكون نيجاتيف. فعشان هيك يسموها ايش؟ acne form lesion. acne form يعني تشبه الأكني لكن it's not true acne. ليش؟ لأن ما عندي comedones. Polycystic ovarian syndrome, this is one of the causes of acne. Usually seen in female patients who are obese, excessive hair growth on the face, irregular cycle, oligomenorrhea, scalp hair thinning, dyslipidemia, glucose intolerance. كل هالأشياء might be a cause for acne. So we need to think about polycystic ovarian syndrome, ovarian tumors, أو adult onset adrenal hyperplasia in female patients who are on optimum treatment for long time without response. And usually those patients shows features of previously mentioned conditions. congenital adrenal hyperplasia adult onset يكون عندي hyperpigmentation ambiguous congenital adrenal hyperplasia patient بيكون عندهم hyperpigmentation ambiguous genitalia excessive urination abnormal hair growth on the face. هذا في pediatric age group. بس حتى في الادلت في عندي شيء بسموه adult onset adrenal hyperplasia. adrenal tumor usually في عندي systemic virilization فيها. يعني في عندي two types of virilization. Virilization means male-like features. يعني في عندي cutaneous وفي عندي systemic. cutaneous اللي هي hirsutism, abnormal hair growth on the face, scalp hair thinning, acne, irregular cycle. هذول بسموهم cutaneous virilization. السيستميك بكون في عندي ايش؟ in addition to those بكون في عندي ايش؟ masculine built للفيميل, clitoromegaly, breast atrophy, deepening بالvoice. فهذه الاشياء موجوده. we need to do investigations to rule out underlying malignancies. Hormone secreting tumor either from the ovaries or adrenal gland. Late onset acne usually seen in female patients above the age of 30. Usually it's confined to the chin area with multiple papules, nodules, cysts, and scar. And sometimes it's resistant to treatment. Complications زي ما حكينا, complication of acne and depression, pigmentation and scarring. Types of scar مطلوب منا مش مطلوبة حاليا. Types of scar formation. مهم نعرف إنه scarring is one of the factors that can classify patient as having severe acne if it's associated with other acne lesions. بس إذا patient جانا عياد عنده diffuse scar formation بالفيس for a few years, هاي خلاص it's burnt out acne وحاليا he's suffering from the complication of acne. There is no point in giving him systemic oral medication because he doesn't have any active acne lesions. So right now راح نبلش ايش بالtreatment of the complication of acne by some laser treatment or any other physical treatment. But our aim of treatment is just to catch the patient at the appropriate time before he ended up with scarring. Differential diagnosis of acne زي ما حكينا, acne comedone. إذا ما عندي comedone, this means that this is not acne. differential الثاني لازم نعرفها بالنسبة للأكني, rosacea and folliculitis. أشياء ثانية hydradenitis, pseudoffolliculitis, باربي مش مطلوبة. rosacea رح نحكي عنها كمان شوي. Pyogenic folliculitis هو عبارة عن infection بالhair follicle. Pyogenic لأنه في عندي بكتيريا. Usually this is seen in patients who are being treated with long-term courses of oral antibiotics to treat moderate acne. Moderate acne, sometimes we use oral doxycycline or topical clindamycin, okay, for 3-6 months. If the patient has been on doxycycline for 3 months, he is on remission, his acne is well controlled, and all of a sudden the patient starts to suffer from recurrent papules, painful papules, and pustules, mainly around the nose, around the mouth. Despite being on doxycycline, the lesions they get exacerbated. At this time, we need to stop doxycycline, take swab culture, and most of the time we can see gram-negative bacteria like Klebsiella or Proteus or Pseudomonas. Why this is happening? Because doxycycline will kill the Propionibacterium acne, reduce inflammation, and it kills the normal flora. So by giving the patient long-term oral antibiotics, we are disrupting the normal flora ecosystem of the skin, which will allow the gram-negative bacteria to overgrow and cause this pustules and papules. So always think of pyogenic folliculitis as the differential diagnosis for acne, especially if there are no comedones. Diagnosis is clinical. There's no need for any further investigations unless there's underlying cause. As we said, from the history, we need to, especially female patients, any patient with acne, ask her about scalp hair thinning, hirsutism, abnormal hair growth in the face, about the cycle. If she's having irregular cycle, most of the time she might need to do investigations to rule out polycystic ovary, adrenal tumors, or ovarian tumors. So to do this, we need to do from the 2nd to the 5th day of the cycle, testosterone level totally free, 6 hormone binding globulin, LH-FSH ratio, dihydroepiandrosterone sulfate, androstenedione, 17 hydroxyprogesterone, and urinary free cortisol. Sometimes if there are features of PCOS or adrenal tumors, we need to do CT abdomen for the adrenals and ovaries, ultrasound abdomen. For the polycystic ovary, the LH-FSH ratio should be more than 2.5. If the dihydroepiandrosterone sulfate and androstenedione are very high, we need to think of adrenal tumor. So in ultrasound polycystic ovary, we need to have multiple ovarian cysts, more than 12. Each one should be more than 10 millimeters. So a single or two incidental cysts are not diagnostic for polycystic ovary syndrome. So our aim of treatment of acne is just to prevent scar formation, reduce the psychological morbidity of the patient, and to resolve the lesions. بالنسبة لسلايد 30 عشان التريتمنت إذا كان simple acne I give the patient comedolytic creams that might contain salicylic acid, glycolic acid, or benzoyl peroxide. I ask the patient not to pick the lesions because if the lesions ruptured inside the skin, the patient might end up with scar formation. Any moisturizer cream, أي كريم مرطب should not be comedogenic. شو يعني comedogenic؟ يعني cream should be lotion based, very thin. If it applied on the face, it should not form thick layer. Otherwise, if it's too thick on the skin surface, it might cause poral occlusion and get the acne exacerbated. So to start with, we need to classify patients according to the severity of acne: mild, moderate, severe. Mild acne, we have comedones. We need to give creams to remove those comedones. Those creams are called comedolytics. Comedolytics. One of those creams, or top most used creams, is topical retinoids. Topical, we have many types: adabalene, tretinoin, tazarotene. Those are used to treat comedones. They cause comedolysis or desquamation of the skin that occlude the poral sites. So if we have obstruction of the poral site, we need something to remove those cells from the pores, which are topical retinoids. Those retinoids causes peeling of the skin. They have anti-inflammatory effect. It needs at least 6 to 8 weeks to start seeing the response. We need to warn the patient about the risk of side effects, which are sun sensitivity and peeling of the skin, burning sensation, eczematous changes. So in the first 2 to 3 weeks of treatment, we ask the patient to use those every other day or twice a week to see if they will develop reaction or not. If they develop severe reaction like burning sensation, hotness of the skin, peeling of the skin, we can use non-comedogenic moisturizer cream in the morning, and we can apply the topical retinoids at the afternoon or the evening. If the patient don't develop any side effects, they can apply it at night on daily basis. Because those causes sometimes peeling of the skin, any deep-seated lesions will be more apparent on the skin surface. So we might expect some exacerbation of the acne in the first 6 to 8 weeks of treatment. Those medications should not be stopped before 3 months of treatment. So we need at least 3 months to assess the final response of those creams. Those medications sometimes can be combined with other creams because they will increase the absorption of any other treatment, as they cause peeling of the skin, thinning of the skin. So the absorption of any other cream that can be used with those medications will be much more easier. Those are teratogenic and they should not be used in lactation. Benzoyl peroxide has anti-inflammatory effect and there is no bacteria resistant to this cream. It's comedolytic, it has a comedolytic action and has anti-inflammatory action. The problem with this cream, also the irritation, burning sensation, contact dermatitis. And we want to warn the patient that it sometimes might cause bleaching of the clothes and hair. Azelaic acid is a natural anti-inflammatory and comedolytic cream. The exact mechanism of action is not known, but it can be used in pregnancy and lactation, and it's safe. Although it reduces the pigmentation, so if we can combine this to reduce the post-inflammatory hyperpigmentation with topical retinoids. Topical antibiotics. We can use antibiotics in dermatology for 2 major purposes. One of them is antibacterial effect, and the second one anti-inflammatory. In acne, we use sometimes erythromycin or clindamycin. They have anti-inflammatory effect, and they can be used with topical benzoyl peroxide to reduce the risk of resistance. But the problem with erythromycin that it can be sometimes, we can see sometimes much resistance, up to 50% of cases. So over the last couple of years, erythromycin hasn't been much in use. Systemic antibiotic can be used sometimes if we have diffuse involvement of the face and back with inflammatory papules and pustules. So if you have a localized inflammatory lesion, then topical antibiotics like clindamycin, benzoyl peroxide can be used. But if you have diffuse inflammatory papules, pustules on the face, back, or large surface area, it's not practical to apply topical creams or lotions on daily basis. Otherwise, the patient may need to use huge amount of lotions and creams, which is too expensive. So a systemic antibiotic like doxycycline, tetracycline, minocycline can be used. They should not be used less than 3 months because of risk of resistance. Tetracycline is not used anymore for acne because of much food-drug interaction. Usually they used to be given 1 hour before meal or 4 hours after food because of the risk of the food-drug interaction. The absorption of those medications is affected by milk, antiacid, calcium, iron, and other supplements. But this is not the case for the other tetracycline like doxycycline or minocycline, which can be combined with food. The major problem with the tetracyclines that with the chronic use they might cause vulvovaginitis. Doxycycline is one of the most commonly used medication. The major side effects is GI abscess. So it's used 100 milligrams once a day for 3 up to 6 months. After a main meal, we ask the patient to drink a large amount of water and to be in a sitting position for about half an hour. If the patient sleeps immediately after taking the pill, sometimes he might have regurgitation, and then it will be complicated by esophagitis. So doxycycline, the major other side effects of doxycycline that it should not be given during lactation or pregnancy because it's teratogenic. It might cause abnormal bone remodeling and discoloration of the neonatal teeth. Also, it has a phototoxic reaction. If the patient takes medication and gets sun exposed, they might develop burn-like symptoms of the face, and they might develop onycholysis, which is separation of the nail plate from the underlying nail bed. Because it's sun dependent, it's called photoonycholysis. The patient takes doxycycline, gets sun exposed, he will have the nail separated from the underlying nail bed. Minocycline is very effective treatment. It's lipophilic and the absorption is not affected by food. Maybe its action is much more potent than the doxycycline, but the main problem with the minocycline that there is a risk that it might cause lupus-like symptoms, autoimmune hepatitis, and pigmentation of the skin. So it's not used as a first line of treatment in acne patients. So oral erythromycin can be used, sulfamethoxazole, cotrimoxazole can be used, but again, those are not desired for regular patients because of these side effects, especially with erythromycin and GI abscess, but it can be an option if you have a pregnant patient with moderate to severe acne and there are contraindications to other medication to be used. Hormonal treatment. As we said, one of the major pathogenic factors for acne is sebum production, which is dependent on hormones. So if we give anti-androgens to patients to block the testosterone receptors, this will reduce the amount of sebum and indirectly will control the acne. So one of the options that can be used is cosibridol, which is an anti-androgen and estrogen at the same time, or something called DIAN, ethinyl estradiol with cyproterone acetate. Cyproterone acetate, it has an anti-androgen effect. It blocks directly testosterone receptors. Again, this is the same case for the ethinyl estradiol. Ethinyl estradiol goes also to the liver and increases the sex hormone binding globulin, which makes the free testosterone much less. Other medication that can be used is oral anti-androgen spironolactone. It's a potassium-sparing diuretic. If it's given in male patient, it might cause gynecomastia, but it's given in female patients who are showing features of high androgen level, or that has used oral antibiotics for 3-6 months with topical retinoids without much response. Spironolactone can be used as another option or a second line of treatment. The mechanism of action, it directly inhibits the testosterone receptors, blocks the testosterone receptors, and again it inhibits the hyperalpha-reductase enzyme level. But the main problem with this medication in female patients that it's teratogenic. A married patient should be on contraceptive methods before we start this. It should start on the second day of the cycle and the pregnancy should be done. The patient can get pregnant safely 3 months after stopping this medication. The other major side effects is headache, abdominal pain, frequent urination, sometimes irregular cycle, and breast tenderness. Now, there are some case reports in mammals that this medication can, in animals, that this medication can increase the risk of breast cancer. Should we do frequent blood tests for patients who are on spironolactone? If the patient is otherwise healthy, below the age of 40, there is no need for any blood tests. But if she's above the age of 40, kidney function test and potassium level should be done in addition to blood pressure management. I usually advise patients to drink much water while on this treatment. Usually we start by dose of 25 milligram twice a day, and within 4 weeks we assess the side effects. If there are no major side effects, then we increase the dose to 50 twice. But it can be an effective medication, and the response usually appears within 4-6 weeks of treatment. Oral isotretinoin. This is one of the most effective medication for acne because simply it works on the 4 main pathogenic factors for acne. Usually it is given for patients with severe acne, patients with nodules, cysts, and scars with active acne, or for patients with moderate acne who use regular treatment, conventional treatment for 3-6 months without much response. So why this is very effective medication? It's oral vitamin A. It goes to the sebaceous gland and causes apoptosis, atrophy of the sebaceous gland. This means that there will be no sebum for the bacteria as a food. The bacteria will die indirectly. This medication has anti-inflammatory effect. So it reduces the chemotaxis from the dermal blood vessels to the dermis. In addition, it works on the comedones by causing peeling effect. So it works on the 4 main pathogenic factors for acne. That's why it's very effective. So it's very effective. There are some side effects and some blood tests that need to be done before going to the treatment. So any patient to start on oral isotretinoin, usually it's approved for patients who are above the age of 13. We do CBC, liver function test, lipid profile, pregnancy test for patients who are married. CBC because there is risk of thrombocytopenia and leukopenia in some patients. Liver function test, ALT/AST because there is risk of hepatitis. Cholesterol and triglyceride level. Some patients might develop hypercholesterolemia and hypertriglyceridemia. And if the triglyceride shoots above the level of 8.5 millimole per liter, the patient will be at risk of severe pancreatitis. This medication is teratogenic, so a pregnant patient should not take this medication at all. If the patient is married and she won't take this medication, she should be on 2 methods of contraception. The medication should start on the 2nd day of the cycle after a negative pregnancy test. Each month, the patient should come to the clinic for a pregnancy test. If it's negative, she can prescribe medication for the next month. The major side effects of this medication is teratogenicity, as we've said. There is also skin side effects, dryness of the skin, nose, eyes, and mucous membrane. Sometimes the patient might develop epistaxis. Dryness of the eyes, we need to use eye drops, lubricant eye drops, and moisturizer cream for the mouth. Because it causes peeling of the skin, it reduces the thickness of the skin. So the patient will develop photosensitivity upon sun exposure. So we advise patients to use moisturizer creams. Other side effects is myalgia, arthralgia. So if the patient is a bodybuilder, he should stop strenuous exercise. There are case reports about rhabdomyolysis with this medication. GI upset, hepatitis, lipid abnormalities, hematological side effects, as we've said, leukopenia, thrombocytopenia or elevated platelets, neurological side effects, pseudotumor cerebri. That's why this medication should not be combined with doxycycline. Doxycycline and oral isotretinoin, both medication will increase the risk of benign intracranial hypertension, which might cause blindness. So the patient develops severe headache, nausea, vomiting, blurring of vision early morning, stop the medication and send the patient to fundoscopic examination. Rarely proteinuria and hematuria. Mood changes. It's still controversial whether this medication increases the risk of suicidal ideation or suicidal attempts. But we need to be careful when using this medication in a patient who has de novo depression. Sometimes the depression can be a complication of acne. So if you use this treatment and the patient started to see good effect, then I think his depression will be much less. Avoid this medication in lactation and in pregnancy. We need to advise patients not to use contact lenses while in treatment. Also advise patients not to donate blood while in treatment, because this medication goes through blood, and if the donated blood is given to a pregnant patient, she might develop side effects. So overview of the therapy, as we said, mild acne, comedone. We want something to remove those comedones, which is mainly topical retinoid. We can use topical benzoyl peroxide and azelaic acid. Moderate acne means comedones, inflammatory papules, pustules. If it's confined to specific area, let's say forehead, we can use topical retinoids and topical antibiotics like erythromycin or clindamycin. If it involves large surface area, we use topical retinoids plus oral doxycycline. We can use minocycline. A second line of treatment is hormonal treatment for female patients and spironolactone for female patients. The spironolactone and the hormonal medication should not be given for male patients. Severe acne, oral isotretinoin. Okay. Now, if the patient is having severe acne, but there are contraindications to go for oral isotretinoin, then a female patient I mean, and she has features of polycystic ovary, then we can go directly to anti-androgens and hormonal treatment, or even spironolactone. So we need to do those blood tests before we start the treatment. If they are normal, we can start treatment by 0.5 milligram per kilogram per day. The dose is not requested from you. And 8 weeks later, we do the same blood tests. If they are normal, we increase the dose to 1 milligram per kilogram per day. We usually use this medication for 4 to 6 months, and there is cumulative target dose for each patient according to the weight of the patient. We go to rosacea, slide 43. Rosacea is a chronic inflammatory condition of the face, usually affects women after the age of 40. Let's say between the age of 30 and 40. Usually those women has white skin. They don't have much pigment to protect themselves from the sun damage. So at the beginning, the patient might present with flushing, sudden onset of hotness of the face, burning sensation, redness that stays for a few hours, and this appears completely without leaving any complication. Now, this is the pre-rosacea stage. At this stage, we can't say that this patient has rosacea. We say that this patient has flushing, and we try to investigate an underlying cause. It could be social, embarrassment, drug-induced, such as calcium channel blockers, phenothiazines. It could be sometimes due to pheochromocytoma, carcinoid syndrome, cavernous sinus, superior vena cava syndrome. So this is called flushing. Now, the patient develops fixed erythema on the face with dilated blood vessels. Now, this is rosacea. White appears on fairy skin individual because sun exposure has a major role on rosacea. So we can't see rosacea on the back, chest, or abdomen because simply sun exposure has a major role. The underlying pathogenesis is inflammation of the skin. When the patient gets sun exposure, they will get inflammation in the skin. Free radicals formation, the blood vessels get dilated, and there is transient endothelial dysfunction with sun inflammation in the skin and edema. So this is simply the pathophysiology of eczema. Blood vessels get dilated, blood flow will increase to the skin is irritable, there's inflammation and edema. The blood vessels get dilated and it doesn't get back to its normal size because of chronic inflammation of the skin due to sun exposure. Now, there are factors that exacerbate the rosacea, like sun exposure, hot spicy food, alcohol, embarrassment, topical or oral steroid. So the symptoms that usually appears is feeling of hotness, burning sensation, irritable skin, especially after sun exposure. Usually the area around the eyes, around the lips are spared because simply by nature those areas are sun protected. So usually we see the rosacea on the fixed non-mobile part of the face, the bony parts, the forehead, the nose, cheeks, chin area. Because of the inflammation and transient endothelial dysfunction, edema of the skin, sometimes we have extravasation of inflammatory cells from the blood vessels to the skin. So we might see inflammatory papules, pustules, but no comedones. Because simply if we have comedone, then this is acne. The lesions are usually symmetrical. We can't see rosacea on only one part of the face, but sometimes we can see the rosacea is more exaggerated in one part of the face, especially in truck drivers who drive for long hours. Sometimes they might have rosacea more on the left side than the right side. So it's a chronic condition. It's with exacerbation and remission. There is no cure, And this condition is not self-limiting. If not treated, it might progress and it might have a huge negative impact on the patient life. So there are some subtypes of rosacea. Let's go directly to slide number 47. The first slide, this slide shows the first stage. On the left side, this gentleman has fixed erythematous patches on the forehead, nose, and cheeks, in addition to the chin area. The area around the eyes, around the lips, are relatively spared. They are not involved because we've said that sun exposure has a major role in rosacea. The skin might become dry sometimes. If we look at the nasolabial fold of this gentleman or the side of the nose, we might see dilated blood vessels. So we have dilated blood vessels, which is called telangiectasia, and we have erythema on the face. So this stage called erythemato-telangiectatic rosacea. Erythema, telangiectasia on the face. The second stage of this lady on the right side, she has erythema, telangiectasia. In addition, she has multiple inflammatory papules and pustules on the cheeks. Look at the area around the eyes, around the lips, relatively spared, not involved at all. So this is called papulopustular rosacea. Papules, pustules, with erythematous background and telangiectasia. This is papulopustular rosacea. Again, on slide 48, this lady on the left side has more prominent papules, pustules, erythema and telangiectasia, with relative sparing of the area around the eyes, and the area around the lips is completely spared. Now this gentleman on the right side, he has something called rhinophyma. It's one of the complications of rosacea. As we've said, the complications are mainly edema of the face, of the skin. There is inflammation of the nose. The nose become boggy, swollen. There is sebaceous gland hyperplasia and a huge inflammation of the skin. This inflammation is fibrous and solid. So unfortunately, the oral antibiotics or topical antibiotics at this stage will not be helpful. So the main treatment is surgical excision or removal by electrocautery or ablative laser treatment. Again, the other complications of the rosacea is eye involvement. We can see rosacea in the eyes. So any patient with rosacea, ask about eye symptoms: burning sensation, foreign body sensation, excessive lacrimation, dryness in the eyes. Up to 50% of patients with rosacea might have eye symptoms. So if the patient is having, and there is no correlation between the severity of rosacea and severity of eye symptoms. A patient with mild rosacea might develop severe eye symptoms. So if you have a patient who are on topical treatment for his rosacea for, let's say, 3-6 months, his condition is well controlled, he develops suddenly burning sensation in the eye, blepharitis, conjunctivitis, excessive lacrimation. His rosacea is mild, but he has severe eye symptoms. He needs to be sent to the ophthalmologist, and we need to upgrade the treatment because the risk of blindness in less than 1% of patients. So always ask about eye symptoms. If the patient, even if the patient is having mild rosacea and he reported eye symptoms, go and upgrade the treatment. We'll talk about treatment in a few minutes. Differential diagnosis of rosacea, acne. Now let's go back to slide number 47. Look at this lady on the right. We said that she has papulopustular acne. Sorry, papulopustular rosacea. What's against acne? She doesn't have any comedones. So I can't say that acne is the diagnosis. Diagnosis is rosacea. Differential is acne. The third differential is folliculitis. The other differential we've talked about in the bulbosquamous conditions is seborrheic eczema. Seborrheic eczema appears on the face as erythematous patches, ill-defined margin because it's eczema, and has greasy yellowish scales. Greasy yellowish scales involve the scalp area behind the ears, nasolabial fold, eyebrows, eyelashes, anterior chest area, armpits, and groin. Sun damage. Photosensitivity sometimes might induce features of rosacea. Lupus sometimes might induce a rash. The rash on lupus is butterfly-like rash, erythema, edema, involves the cheeks, sparing the nasolabial fold. There is no persistent telangiectasia, and it's transient. It doesn't stay for ages as rosacea. Drug induced, sometimes we have medication that might be used and gives usually features of rosacea like steroids on the face. So if you use topical steroids on the face for a long time, it might cause thinning of the skin, dilatation of the blood vessels. So that's called steroid-induced rosacea. That's why if you have a patient with vitiligo or psoriasis on the face, we can't use steroids for a long time. And it's usually contraindicated even to give steroids on the face or groin because of the side effects. So that's why we give steroid sparing agents, something just like steroid without side effects, like tacrolimus or pimecrolimus. So slide number 50 compares the rosacea and acne. We've mentioned all of this. Now the treatment, if we have a patient with telangiectasia and erythema of the face, then we need to go for physical treatment. Telangiectasia are dilated blood vessels in the skin. If we want something to remove those blood vessels, unfortunately we don't have medical treatment for this, but sometimes laser treatment might be helpful. We have a laser treatment that's used to treat vascular malformation or vascular tumor. It's called pulse dye laser. Usually it's done in sessions to remove those blood vessels from the skin. Sometimes we can use alpha-2 agonist cream to cause brimonidine sulfate to cause vasoconstriction of the blood vessels of the face. But unfortunately, it's just a symptomatic treatment. Once it's stopped, it might cause rebound effect. If we have inflammation of the skin, then topical metronidazole. Why metronidazole? We don't know, but by chance they discovered that metronidazole topical treatment can be helpful as it has anti-inflammatory effect. Topical azelaic acid usually is used in acne and pigmentation of the face, can be used in rosacea. Before going through this, we need to advise the patient to avoid any triggering factors like sun exposure. So we need to use sunblock. We need to avoid using soaps because the patient has irritable skin. So we need to use moisturizer creams. In addition to this, we need to avoid hot spicy food, avoid hot drinks, avoid stress. Papulopustular rosacea, we use medication that has anti-inflammatory effect. Again, topical metronidazole, topical azelaic acid. Oral doxycycline can be used. How it works? It has anti-inflammatory effect. It reduces the chemotaxis. We don't have bacteria on the skin of patients with rosacea. So doxycycline here is used for its anti-inflammatory effect. But again, be careful that doxycycline, one of the side effects of this medication is phototoxic reaction, which means if the patient starts to use doxycycline and after 2 weeks, he came to the clinic with diffuse burning sensation, burn-like symptoms of the face, most likely this is a side effect of doxycycline, and doxycycline should be stopped immediately. Phymatous rosacea, as we said, rhinophyma, boggy swelling nose. There's no topical treatment or oral antibiotics to treat this condition. So at that time, we need to use electrosurgery or ablative laser to remove that tissue. Ocular rosacea, we need to use lubricant eye drops because dryness in the eyes, foreign body sensation. Oral doxycycline can be used. Please, if you do have any questions, don't hesitate to send me. Thank you.